Hey everyone, Professor G here, and today we're going to be covering joint injections. Clinical clerkship, we cover lots of different procedures, and today we're going to be covering how to inject joints. So the two joint injections we're going to be covering today are going to be the knee injection and the shoulder injection. Today's video will include an introduction to the two procedures. We'll talk about indications, contraindications, complications, pearls and pitfalls, and we'll even talk a little bit about some of the post-care instructions we'll want to give to our patients. Uh, we'll also go into an explanation of the different instruments we're going to be using, as well as the models that you'll have in your lab. Lastly, I'll do a demo of both the knee injection and the shoulder injection with trying to follow the rubric as best as I can so that you can get a nice instructional video to follow when you're trying to practice. In that video, I'll also include how to obtain informed consent and some of the things that I would tell my patient after the procedure is done as far as post-procedure instructions and care. So like I said, the two joint injections we're covering today are going to be a knee injection. Now, when we do knee injections, we can do them from multiple different approaches. And the approach that we're going to cover today for lab is going to be the medial approach. For the shoulder injection, now, when we say shoulder injection, what we actually mean is a subacromial bursal injection. Okay, so they kind of synonymous with each other. People say shoulder injection, that's what they mean. And there are three different approaches that can be done for this, but today in lab, we'll be covering the lateral approach. In lecture, I'll make sure to cover all the different approaches and when to use which one. First of all, we're going to be doing a knee injection. Now, when we do knee injections, we can do just an injection, or we can do an injection and aspiration, depending on the indication. The indications that we have listed in our textbook are for both a knee injection and aspiration. Now, in lab, we won't be requiring you to do an aspiration, just an injection, but keep in mind that these indications are for both procedures. The indications would be a diagnostic evaluation of an effusion. So whenever you have an unexplained swelling of a joint, especially the knee, we need to figure out what's causing it, right? And so we would go in to try to remove the fluid and send it off to the lab. Also, we want to limit joint from becoming infected or inflamed. So we're going to remove fluid. Anytime we have stagnant fluid, it has a higher risk for becoming inflamed or infected and causing pain. We also can do it to remove fluid for symptomatic relief. Although we rarely do this, we can do it. And basically what it means is when something's swollen, it tends to hurt. And so we can go in and symptomatically remove large joint effusions to help relieve the pain, although it is very temporary. And so very rarely do we ever do this, especially in the emergency department. Do we just say, you know what, your knee's pretty swollen, let me take some fluid off just to make you feel better, because the patients are going to expect that every time they come in. But we have and can use this as a means of temporary relief for the patient. Another thing we can diagnose by removing fluid, which we covered in ICM, would be a crystal-induced arthropathy like gout or CPPD. We can also use it as a means of administering viscous agents, right? So viscous agents help lubricate the joint and help it move more fluidly. We can also use it, and kind of what we'll be doing in this video and in our demonstration is administration of glucocorticoids to help with different things, osteoarthritis, gout, pseudo-gout. There's many indications for giving steroid injection in the knee. As far as contraindications, anytime we're going to be injecting something, we want to make sure that there's no infection present, because we don't want to introduce a needle through infected skin. Because if there wasn't a joint infection, we can introduce one iatrogenically. Other things, we don't want to do these procedures if we have a high risk of bleeding, coagulopathy. If we have a patient that's not cooperating, we can't put a needle into a joint. It's going to be very difficult. With any type of steroids that we use, we want to not inject steroids into an infected joint, because it will definitely make the infection worse. If you're not familiar with the procedure, now we always teach the see one, do one, teach one when we talk about procedures, but definitely you want to have someone there that's familiar with the procedure that can help guide you through if it's one of your first times, or maybe you're not familiar with the procedure and that approach. If you have a joint prosthesis, so if you've had a knee replacement, you're going to want to have an orthopedic physician take care of that knee from then on out. They kind of like sign that knee over to themselves for the rest of that knee's life. Steroid injections should also be limited, right? We don't want to do them every 2 or 3 weeks, every month. We definitely want to space it out. I would say maybe 2, 3, 4 times max per year. And especially want to be careful in diabetic patients because the knee is a pretty large joint. And so we're putting quite a bit of steroids that can be absorbed systemically, and you can have some trouble controlling their sugars because of it. I would not recommend doing any type of injection, joint injection in children without the recommendation of a specialist. So if you're the PA in a specialty pediatric orthopedic unit, then by all means go for it because you're the specialist. But otherwise, I wouldn't recommend just the average family practice ER urgent care PA getting a little bit gung-ho and going for the injection in kids and other conditions. As far as complications are concerned, it's actually pretty rare to introduce an infection. Say it's less than 1 in 10,000 procedures. So obviously we want to take care to clean the area and use sterile technique, but just keep in mind that it is pretty hard to actually introduce an infection. After you have put the steroid in, usually we put steroids in with numbing agents like lidocaine or marcaine, and that can cause make the knee more vulnerable to injury. So when you can't feel something, it's kind of like when you go to the dentist and they put that numbing medicine and then they tell you not to eat because you can kind of bite your tongue or bite your lip because you can't feel it. So you should avoid strenuous activity or recommend your patients avoid strenuous activity for about a day after the anesthetic to let it wear off so they can kind of feel if they're putting too much strain on their knee. Also, it's good to mention to the patients that you can get a post-injection flare. So usually it gets worse before it gets better. And I love to tell the patients that because they're expecting a quick fix. Anytime patients get a shot, they're thinking quick, it's going to feel better right away. And they don't expect it to feel worse, but you want to prepare them for that by explaining how they can get it a little worse before it gets better and recommend using NSAIDs and ice to help get through that. Most of the visco supplementation products have chicken, some component of chicken in it. So you want to definitely ask about allergies. And theoretically, steroids can cause degeneration of the articular surface. And this is why we recommend only doing it, maybe 2-3 times a year. As far as pearls and pitfalls, like I've said before, the more you do these procedures, the better you'll be at them. Many times nowadays, ultrasound is becoming a really popular means of doing procedures effectively and hitting the mark every time without question. And so nowadays, most providers are using ultrasound guided injections, even in the emergency department. Some of the things we can do. So the underside of the patella, as we remember from anatomy, is curved. And so the further we can stay away from the middle of the patella, the easier and more room we have to inject the needle into the knee. Anytime you do an injection, you're going to do a smooth, speedy or quick insertion of the needle. The longer you take to kind of inch that needle in, the more pain you can cause. Whenever you get the needle into the joint, you can aspirate to kind of see if you get any fluid back and to make sure that you're in the joint space. When you push that plunger, it should flow very freely. There should be no resistance. If you do meet resistance, you're probably not where you should be. And so you should readjust. If you hit bone, sometimes when we go in, we don't go in at the correct angle. We might hit the underside of the patella. And if we do, we want to back out and re-angle our needle. Lastly, try not to hit anything if you can avoid it. I mean, I know we're learning here, but we want, anytime we touch any type of surface, bone or otherwise, it hurts the patient. So we want to try to make this as smooth and painless as possible for our patients. As far as post-procedure instructions, after we're done with our procedure, we're going to tell them about the risks and benefits we already told them about prior to. We want to remind them about not getting too frequent of steroid injections. If we've put in local anesthetic, We should avoid strenuous activities for the rest of the day. Like we said, we can't feel the pain in our knees, so we might get a little more aggressive with the actions, but we should recommend our patients not do that. We should also encourage our patients to look for signs of infection like fever, pain, warmth, redness of the knee. Usually the knee will start feeling better right after the injection because of the anesthetic. Then it'll start to feel worse before it gets better. Usually takes about 1 to 2 days for the steroid to really start to take effect. Whenever we do the steroids or viscosupplementation, like we said, they can have a flare. So encourage ice and NSAIDs, and definitely make the patient aware that that can happen. Osteoarthritis, patients should understand that no injection is going to be a permanent fix, especially with osteoarthritis, as we see over time, it continually and gradually worsens. So we can recommend steroids. We can also recommend viscosupplementation. Really depends on your practice. If you're in an orthopedic clinic, you're going to be aware of what is being done to the patient and what has been done, and make recommendations accordingly.
All right, so now we're going to discuss our equipment and our materials that we'll use for our knee injection. So our models that we have in the lab, if you can see, the fibula and the tibia. So we know which side is lateral and which side is medial. For our practical, we're going to be doing the medial approach. So if you're right-handed, you'll want to get on the right side of the bed to approach the knee medially on this side here. The knee actually has a patella. You can feel it underneath here. And so when you go to grab it, you'll want to maneuver and kind of know where your anatomy is on your model. So that's that. Other things that you're going to need are a pair of non-sterile gloves, a pair of sterile gloves, and then we'll also need our medications. One is lidocaine, the other is our steroid that we're going to be using. We'll need some iodine or chlorhexidine, whichever you want to use for it. We'll also need some alcohol swabs, and those are to swab the tops of our medications. We'll also need a syringe to administer the medication. In this case, we have a 10 ml syringe with a 22-inch long needle. For the knee, you're probably going to want to use 1.5 inches to really get within the joint space, so I have that here too. In our practical, we are not requiring you to withdraw fluids from the knee, but in most cases when you're giving an injection in the knee, at least in the emergency room setting, it's because there's excess fluid. We're trying to withdraw that fluid and then give the injection. And so if you're going to be aspirating and getting fluid out of the knee, you'll want a large syringe. This one is 60 mLs. And you'll also want a large bore needle, like an 18 gauge needle, to suck that fluid out. Other things that we have are some cotton swabs and our Band-Aid. So next I'm going to go ahead and demonstrate. And while I'm demonstrating, even though on the practical you're not required to do this, I will mention when would be the appropriate time to withdraw fluid if you have a large effusion that you want to take some fluid out for. All right, so let's do the demo. All right, so now we're going to demo our knee injection. And here we have our patient. Although for the purposes of this demo, I have the patient kind of turned sideways so that you can see where I'm working. But obviously in real life, you're going to have the patient laying here, and you're going to be working on the leg further away from you, right? Because you're approaching it from the medial side. So you will have a leg here in your way. Just keep that in mind whenever you get out in the clinic, okay? So first we're going to introduce ourselves to the patient. Hi, I'm Christina. I'll be your physician assistant taking care of you today. Can you go ahead and verify your name and your date of birth? Once the patient does that, then we can discuss the procedure with them, tell them what we're going to do and why we're going to do it. The indication we talked about earlier, there's a lot of different indications for a knee injection and aspiration if we're going to be aspirating. A lot of times osteoarthritis is the main one we'll see, like in the outpatient clinic. Other things like monoarticular swelling, that when we want to try to analyze fluid and see what it's causing it, gout, septic arthritis, things like that. So whatever the indication is on the folder that you draw in the practical will be what you discuss with the patient. Also want to discuss risks and benefits of the procedure. Risks would be anytime we put a needle in the skin, we risk introducing infection. We are injecting steroids, so we can inadvertently raise the blood sugar. We can cause pain, bleeding, swelling, increased swelling, and those are some of the risks and potential complications. The benefits would be that if we can put steroids in here and there's an inflammatory condition, it should improve the patient's pain and range of motion, make them feel better. Alternative treatments, like we said in the shoulder injection video, most of the time, by the time they come in and they're needing an injection in the knee, they've tried most of the alternative treatments, or at least we've tried to give them those alternative treatments, which include oral medications, physical therapy, rest, ice elevation, those kind of things. Lastly, if the patient does refuse to have the procedure, you can tell them the risk of refusing is that their knee pain might not improve like they would expect it to. All right, so once we've told them all those things, we're going to gather our supplies that we talked about in the materials portion of this video. We'll get everything situated, get it all ready to go, because we will use sterile technique. We want to have everything where we need it. Next, we're going to go ahead and wash our hands, and then we will grab our non-sterile gloves. So I'll go ahead and put those on. So for the practical, we're going to be injecting a steroid and a little bit of lidocaine. So we will have 2 vials to simulate those 2 medications. In this case, we'll say that we're doing 40 of Kenalog and 2 of lidocaine. So the first thing I'm going to want to do is grab that and prepare our syringes. So we'll get an alcohol swab. We'll wipe the tops of both of our containers. I'll get a 10 cc syringe, or 5, whichever you have in front of you. And we'll go ahead and withdraw the medication. So I'm going to withdraw 40 milligrams of Kenalog. And so I'll just simulate that here, withdrawing 40 milligrams. You'll have to see how many mLs that is. I'm not 100% on that. I want to get the air out of there. Then we will prep the other one. Go ahead and withdraw the 2 mLs of lidocaine. All right, we have what we need. Make sure all the bubbles are out of there. For the purposes of our procedure here, we don't want to inject any liquid in there. So what I'm going to do, just for the sake of this video, is put this back, because we don't want any fluid in our simulated patient. All right, I'm going to go ahead and wipe this off. Don't do that in practical, but all right, so we have our other syringe here. All right, so we're going to take a medial approach for our practical. There's multiple approaches to the knee. There's lateral, medial, anterior, but for the practical, we're going to do a medial approach. And so we want to kind of palpate our landmarks. I like to do that kind of first to see what kind of knee we're dealing with, especially if the patient has osteoarthritis. A lot of times they'll have a lot of osteophytes and the knee just doesn't look like a normal knee. So you'll want to kind of get in there, palpate your landmarks, and know where you're going to go. Then once you do that, you've prepped everything. We get the patient in the right position, which is supine with the knee slightly flexed. And we can go ahead and remove our non-sterile gloves and put on sterile gloves. I'm not going to put on sterile gloves for this, but we would have our sterile gloves, put those on, so we're ready to go. Now we're going to place our gloved hand around the patella, which will be our left hand. I'm right-handed, so I'm going to use my left hand. Ends up being kind of my throwaway hand because it will end up touching an area that's not clean. So we'll place our gloved hand around here, around the patella, okay? Now, for this approach, we're going to be pulling the patella medially, and you can actually feel it on our patient here. You can feel it pulling medially, and then the thumb kind of lifts the patella just a little bit to open up the space here to allow the needle to go through. So you're gonna kind of lift and elevate the patella, and your thumb kind of points you in the direction where the needle will be. And usually it's about right here. Now for our procedure here, we're not going to put any local anesthesia, but a lot of times if you're going to be withdrawing fluid, like in the emergency room, you'll want to prepare a separate syringe and a separate needle to apply a little wheel of lidocaine here before you start injecting into the knee. All right, so now we're going to prep the knee using our dominant hand, because we'll have sterile gloves on already. So we probably have an assistant that will open this up so that you can prep with the chlorhexidine or betadine. This hand is done for. It's not sterile anymore, so you're just going to keep it there. You don't want to move it and do anything. And so that's the sterile area. Once you prep the knee, you don't want to start touching on it anymore. You already have the area that you're going to go in. So have our needle that's prepped with our medication. We want to go ahead and take the cap off. and we're ready to go. So with my non-dominant hand, I have it here. The approach is 45-degree angle. I'm not good with angles, but I know that the patella is concave or convex underneath. So we don't want to go too superficial like this, or we'll hit the underside of the patella. And if we go too straight up and down like this, then we won't hit the joint space. So it's about a 45-degree angle. I'm pulling with my left hand and lifting with my thumb, and I'm injecting right here. Should feel it go straight in like that. Once it goes in there, it goes in about an inch. You should feel it in the joint space. If for some reason you hit bone, let's say I go too superficial and I'm hitting bone right here, you'll want to pull out a little bit, redirect, and push in. Okay. Now here you're going to push the plunger. If you feel resistance, you are not in the right place. You want to pull out and redirect your needle. If you don't feel any resistance like I did there, then you know that you put the medicine in the right place. And the procedure is really quick. Once you put that medicine in, you're going to withdraw the needle quickly and probably bleed just a little bit, so you'll have your little cotton ball that you can apply pressure with. And you'll get your sterile bandage. You'll open that and put that on the knee. Okay. That's for if we're just injecting, which is what we're doing on the practical. Earlier on, we would have used this to withdraw fluid, and that would have been the first step we did, but we're not doing that for the practical, so don't worry about it. Once we're done with that, we can discard of our sharps and all the rest of our materials in the trash can, and we can explain the post-care instructions to the patient. Post-care instructions for this would be that we don't want the patient to overuse their knee. A lot of times they feel better quickly because of the lidocaine we put in, but a lot of times they experience a steroid flare where they get a little worse before they get better, so we do want to tell the patient that. Some other things we want them to look for are signs of infection. Even though we use sterile technique, we can always introduce an infection anytime we put a needle into the skin. So we'll tell them to look for any increased redness, increased pain out of proportion to what they think they should experience after an injection, and just to kind of keep an eye on the area and kind of rest a little bit, not completely not using it, but you want to underuse it a little bit for the next 48 hours or so, and then establish follow-up with the patient. So that's the knee injection that we're going to be doing for our practical. And in a second, I'm going to demonstrate how to actually withdraw fluid whenever you're doing this procedure, and adding on the aspiration portion. All right, so this is not included in your practical, but I think it's important to show. So if we're going to be withdrawing fluid out of this knee, what we'll probably do initially is put a little wheel of lidocaine here. So I put a little wheel of lidocaine wherever I'm going to be injecting, and that's to make it more comfortable for the patient. Once we do that, we'll want to put a pretty large needle, usually about an 18 gauge needle, on our withdrawing syringe, and we usually need a pretty big one. It's about 60 mLs. So we'll put that big large bore needle on there. It's usually a little longer than that. This is only an inch, but we probably need about an inch and a half. And so what we'll do, it's nice and numb there, so we'll start there, we'll lift, and then we'll inject in there. Now, once we start withdrawing here, we should be getting yellow straw colored fluid. If it starts looking a little pus filled or cloudy, that's an indication that we could have a septic joint or crystal that are forming within the fluid. So then we will withdraw as much fluid as we need to take it off the joint to make the patient feel better. And then we can actually leave it there and put our medication on there and go ahead and inject the medication now that we have this in there. So that's another way to perform it. If we're going to be administering medication, you're already in the joint after you've aspirated. So then you can just put your medicine on and inject it in there. So that's if you're going to be doing an aspiration along with an injection. And like I said, depends what setting you're in. If you're in the emergency setting, a lot of times this is the procedure you'll be doing. If you're in the orthopedic office or family practice and you have routine patients coming in for knee injections, you'd probably do a different approach than the one that we demonstrated today.
Moving on to shoulder joint injections. So when we talk about the shoulder, again, we're talking about the subacromial bursa. And there are three different ways to approach: the anterior, the posterior, and the lateral. For our instructional video and our procedure in the lab, we're going to be requiring the lateral approach. So some of the indications for shoulder joint injection are going to be impingement syndrome, which is one of the most common causes of shoulder pain, calcific tendinitis, supraspinatus tendinitis, subacromial bursitis, and adhesive capsulitis or frozen shoulder, which are some of the things we might have learned about in ICM. As far as contraindications are going to be similar to what we've seen in the past. So someone that can't sit still for you to put a needle, it's definitely not safe to try to put a needle in a patient if they're not going to cooperate with you. You can risk poking yourself or poking them in a place where they shouldn't be poked. Anytime bleeding, coagulopathy, any infection over the skin. One other one that I feel is one that we should probably remember, because it's very specific to the shoulder, is if we have evidence of a complete rotator cuff tear, we do not want to inject the shoulder. Also, like we said with the knee, if they have a prosthesis, that's a big no-no. That joint belongs to the surgeon for the rest of its life. As far as complications, anytime we're injecting a steroid or anything through the skin, we can induce skin atrophy. We can rarely cause some vitiligo around the injection site, some dystrophic calcification. If we're introducing steroids, we can increase the blood sugar for those patients, especially those diabetic patients. We can induce tendon rupture, post-injection flare that we talked about with the knee. We can introduce an infection, although that's a very, very rare. We can give the patient a Cushing syndrome. Usually in the shoulder, we don't usually see this type of side effect because we're not putting in that much steroid. Well, if we have a greater frequency, which we shouldn't have, we can see a Cushing syndrome from the steroids. You can also see cataracts and facial erythema. These are all pretty rare complications, but you should definitely make the patient aware that they are potentially possible, even though they are rare. As far as pearls and pitfalls of the shoulder, injection of the subacromial bursa, like we said, is the typical shoulder injection. Same thing with the knee. Anytime you do an injection in a joint, nowadays ultrasound is pretty easy to access, and most providers are getting more and more training on it. So if you're doing this with any frequency, you're probably going to want to become better versed in ultrasound. Even the most experienced providers miss the bursa, and some pretty frequently miss the bursa. So you want to definitely use the ultrasound if you have it, if you have access to it. You'll want to definitely aspirate before you inject. Anytime we do an injection, we want to make sure we're not in a blood vessel. If it feels difficult, if you feel like you're in the joint and you're pushing the plunger and the medicine is just not going out, you're not where you need to be. You need to back out. Sometimes we can accidentally inject or stick our needle into a tendon, and that will cause some resistance. So you should feel the fluid just go straight through. It should be really easy to push. The other thing that they mention is just kind of a pearl. Not all pearls you have to follow. They're not ingrained in stone, but a lot of providers avoid inserting the needle directly midline on the lateral aspect because the humeral head is convex, right? And so that if you think about the joint space, the more close to the middle, the less space you have to put that needle in. Although on our models in the lab, which we'll look at briefly, we should be able to insert it in the middle, at least for our lab purposes. After we're done, very similar to the knee injection, we're going to have them remain seated or supine for probably around 30 minutes after the injection. We want to keep them there, have them remain in the office and monitored. We also want to avoid strenuous activity. This one says for 48 hours, usually 24 to 48 hours, because we want that joint to kind of rest and get those steroids on board. One thing we can do is if we're injecting some lidocaine or some marcaine along with our steroid, is shortly after that, we can actually have them come through and do some passive range of motion. And if we put the medicine in the right place, patient's going to feel better pretty quickly. They're going to feel that improvement pretty quickly, and that will help ensure and help give you confidence that you place the medicine in the right place. Same with the knee. We expect, or we can expect, a little bit of a flare, a steroid flare. So we'll recommend ice and NSAIDs. and rest for the first 48 hours or so. And that should help get them through that little flare up. As far as a follow-up examination, we should definitely recommend that they follow up with whoever injected the medication within about 3 weeks of the injection. And that is about it for the introduction. Next, we're going to be showing you the different tools that we use, as well as the models that we use in the lab. So see you shortly.
All right, so the next part of our video is going to be discussing the materials that we need for our shoulder injection. So for our shoulder injection, we have this model. We also have an older model that's a little lighter color skin, and those are the two models we'll be using in our lab. As far as the models are concerned, they do have this little box that has a battery connected to it that should make a little beeping sound when we inject in the correct position, although I will say that it doesn't always work appropriately, so just because you don't hear the beep doesn't mean you're not in the right position. The little box is connected to a wire, which is connected to a special needle that we use to inject. And so don't try to replace these needles. Whenever in the procedure, when it tells you to replace needles or this and that, we'll use a separate set for that. As far as the separate set, you can grab a 10 cc syringe connected to like a 22 needle. That would be how you would draw up your medication. And then when it tells you to replace the needle, you can replace it with this, set that down, and then pick up this one to do the actual procedure. So what we have here is this disposable 10 ml syringe with the 22. We have a 22.5 inch. We also have our alcohol swabs, one for the vial and the other for the patient. Have some cotton, and we have our sterile Band-Aid. So this is all the equipment that you'll need to do a shoulder injection. And so next we'll go ahead and do the procedure. All right, so now we're going to go ahead and demonstrate our shoulder injection. We have all of our materials here. We have our patient, and so the first thing we're going to do is knock on the door, introduce ourselves to the patient. Hi, I'm Christina. I'll be the physician assistant taking care of you today. Can I verify your name and date of birth? You want to do that first. Then you're going to want to discuss with your patient and acquire informed consent. So you're going to tell them about the procedure that you're about to do before you ask them if you can do it, right? And so the indication, we know there's a long list of indications for shoulder injections. We already discussed that in the first portion of this video, but one of the major indications would be like shoulder impingement. So we're going to go ahead and do this procedure on you because you do have some shoulder impingement. We'd like to put some medication in your shoulder joint to help you feel better. Some of the risks and benefits that we talked about earlier in this video were injecting. Anytime we inject in the skin, we can introduce an infection. Anytime we introduce steroids, we can raise blood sugar. We can cause a localized swelling and pain. And those would be some of the risks. The benefits, of course, in most cases outweigh the risks, in that it'll make the patient feel better, it'll reduce inflammation, and get increased range of motion, make the patient feel better. Alternative treatments for the patient, I think they already know. Most of the time, by the time they need an injection, they've tried everything else. They've tried ibuprofen, they've tried other more potent anti-inflammatory medications, and it hasn't worked. That's what's led them to this point to begin with. But if it's early on, you can discuss alternative treatments with the patient. You'll also want to tell them complications, which is similar to the risks, right? So we kind of already touched on that a bit. And lastly, risk of refusing the procedure. Well, in this case, the risk of refusing is probably just that they might not get better, right? This is kind of the last step before considering other surgical options for the patient. So that's what we would tell them, if we don't do this, shoulder likely won't improve, and that's mainly the risk. In my case, I don't tell them the risk of refusing unless they refuse. But for the practical purposes, you do need to tell the patient what the risk of refusing the procedure is. Next, you're going to gather your supplies. I already have all my supplies here. And I'm going to wash my hands, and I'm going to place non-sterile gloves on. A shoulder injection is an office procedure, most of the time in an orthopedic clinic or sometimes even in a family practice clinic. And so what we'll do is put our non-sterile gloves on. These are the gloves that we grab off the wall in the room. Then we're going to prepare our medication. So we'll get our syringe. It can be a 5 or 10 ml syringe. We're not getting that much medication. We will also get our vial of medication. You want to check to make sure it's the right medication, that it's not expired. In this case, we're going to be injecting Depo-Medrol and a little bit of lidocaine. So for practical purposes, we're going to go ahead and simulate drawing up the medication. So I pop the top off, wipe it down with some alcohol, pull up however much I need, which in this case would be about 0.5 mLs of Depo-Medrol, and then also about 2 mLs of lidocaine, which would be a different vial. So 0.5 right there, and then you want to get your lidocaine, clean that one off, and put the 2 mLs. So that's a separate one. You drop 2 mLs, you have about 2.5 mLs then in your syringe. I'm just simulating that because I don't have 2 different vials. You'll have your medication ready to go. Be careful when recapping needles like we talked about before. And then we put on our injecting needle. In this case, I have a 22.5" needle. But for our dummy purposes, we're going to be using the needle that comes with the kit, which would be this one. So there, we talked about in lecture, we will talk about different approaches to the patient. One is anterior, lateral, and posterior. And so for the practical, we're going to be doing the lateral approach. All right, and in the lateral approach, the patient's sitting up in a comfortable position with their hand on the affected side resting in their lap. And we're going to have the patient try to relax. We're about to poke them, so they might not be super relaxed, but try to have them relax. And if, as we're palpating, we can't find a good joint space there, we can also have our nurse or someone kind of pull traction down to give that space and open it up. When we're palpating for our lateral landmarks, I like to follow kind of the spine of the scapula, and as it starts wrapping around, then I know that that's the acromion, and I follow that laterally until I feel this space just under the acromion and above the head of the humerus, and that's kind of where I'm going. Now we know the acromion has kind of a little concave point towards the middle, so even though we're going lateral, they do recommend not going exactly in the middle. Although for practical purposes, as long as you're taking the lateral approach, you should do okay. Once I've found my landmark, I'm going to take, I usually like either the tip of a cap needle or a pen, and I'm going to make my mark. So once I find that, which is just under the acromion, I'm going to make my mark there so I know where I'm going. If you mark it with a pen, chances are when you clean the area, it might rub off, so it's better to use the cap. All right, once we have that, we're going to prep. So you can either use some alcohol or some chlorhexidine or betadine, and essentially what you're going to do is get in here and use concentric circles to wipe and to get that area nice and clean. Then we would remove our non-sterile gloves and put on sterile gloves, although I don't have any for this demonstration, so I'm just going to go ahead and keep these on. The skin is prepped. You want to let it dry, don't want to blow on it, don't want to wipe it, and then you're going to get your needle. So this one is the one that comes with this kit, so that's the one we're going to be using. When we already have our landmark, we have our mark here, and so what we're going to do is we're going to go in and straight in pretty much just underneath the acromion. So go in like that. On this case, sometimes you'll hit bone, and if you hit bone, you have to redirect the needle. And in this case, you should hear a beep. If you don't hear a beep, it doesn't mean you're not in the right position. It just means that the beep is not working. We just tested this one out a few minutes ago, and it did a little beep, but it was very minute. So I hear it barely. No, can't really hear it. There it is. So we're in the right position. Then we would aspirate a bit, push the medication. You should not feel any resistance when you push medication into a joint. It should be smooth and easy to push in. Once we've inserted the medication, we'll go ahead and remove the needle in a smooth, quick fashion. We'll place a piece of cotton here if they are bleeding, and then we'll get a sterile bandage and open that and place that on there. If there's any excess betadine, we'll want to wipe that off because it does tend to be itchy for the patient. Then we'll want to dispose of all of our sharps and our trash in the appropriate containers. And we'll take off our sterile gloves, wash our hands, and explain the post-care instructions to the patient. In this case, we want to tell the patient not to use their shoulder too much. We don't want to keep it completely immobilized, but we also don't want them to go and pitch in the majors, right? We want them to chill, relax, And that should be for the next 24, 48 to 72 hours. Also, after a procedure like this, we like to keep the patient in the office for at least 30 minutes to monitor to make sure that the shoulder feels better and that they're not having any trouble, with vasovagal and things like that can happen when we inject patients. And so we'll monitor them for 30 minutes. You'll want to verbalize this in your practical. Other than that, we'll ask the patient if they have any questions, and we'll get them set up to go home, and we'll follow up with them, of course, to make sure that they have continued improvement of the shoulder. A lot of times, actually, because we inject some lidocaine, patients with certain conditions will actually feel better pretty quickly and regain some range of motion. So that's another trick to know that you got it in the right space, the medication. So anyways, that's the procedure, and thank you for watching this video.